Hi, my name is Tammy Kindel. I'm the Director of Bariatric Surgery at Froedtert in the Medical College of Wisconsin, and today I'm going to be presenting to you emergent complications after lap band. What do you see and what do you do? Luckily, emergent complications after lap band are a relatively rare occurrence. However, there's a couple things to think about when you're seeing these patients in an emergency setting. And like any bariatric operation, history is key. The way that you approach a patient with a band will vary if they've had an adjustable gastric band versus a non-adjustable gastric band, which is a fixed object. Some patients will say they've had a band and what they've really had is a VBG. And so making sure that you try to differentiate between the procedure that the patient's saying they had and what they've actually had before you take them to the operating room will save you a lot of trouble and struggle. A lot can be learned by a plain x-ray in a band patient. So if you get a band, an x-ray, and they've got a gastric band and tubing and a subcutaneous reservoir, you've confirmed that that's an adjustable gastric band, and you can proceed with your plan of care. Just to highlight a little bit of the band shape, these are two commonly used bands in the late 2000s. The band itself with a buckle, you can see the buckle looks slightly different on these, but the way I approach them both is similar. I usually cut the side portion of the buckle, and with that you can unbuckle the band and remove it from around the stomach. The tubing is also slightly different, where the realized band is connected at the port, whereas the lap band is one unit with a junction that's a little bit more distal, and so it's important to make sure that you don't separate the junction of the tubing to the port as you're removing it. Immediate postoperative complications obviously can sometimes present as an emergency, but I hope that most of the time that these are happening at the setting where the band was placed, and with the low utilization of the band, I think that it's less likely that you're going to encounter an immediate postoperative complication. So I'd really like to highlight two more long-term complications of the band. The first is a gastric prolapse, and the second being a band erosion. For a gastric prolapse, or what we call a slip, this is when inferior stomach herniates above the band itself, and you've got a lot of redundant fundus sitting above the band in that superior location. This can happen with more anterior stomach or posterior stomach, and the patient can present in a more chronic fashion with slow to develop intolerance to PO, worsening reflux, or it can present more acutely with an acute change in presentation and ability to drink. Be wary of the patient that presents with pain, as this may be a sign of ischemia. You can diagnose this by history to start, and then usually an upper GI is useful to confirm, as well as to evaluate the passage of contrast through the band. The initial treatment, in my mind, is always deflation. So if you have a band needle or any kind of needle you can access in the emergency room, even if it cores out some of the reservoir itself, you're addressing this acute problem. Is to remove all of the fluid that you can from the band, and sometimes just getting a 1 centimeter extra bit of room of the band will allow that patient to begin drinking again, and you've taken an emergent situation to an elective situation. For a patient that cannot tolerate PO after deflation, or they're having pain, certainly any hemodynamic concerns or laboratory concerns, you need to be cautious of those patients for risk of ischemia. This is just an example of an upper GI showing a significant prolapse. The band should normally be oriented towards the left shoulder at a 45-degree angle, and so this horizontal location of the band is very suspicious of a slip. Obviously, having all of this superior stomach confirms that, and in this patient, they have complete inability to pass contrast. When addressing a prolapse emergently, when they've failed to improve with band deflation, I remove the entire band at that point. So I divide the capsule, usually with the energy device, then identifying the plastic of the band itself, rotating the band until I come to the buckle, cutting the side of the buckle to unbuckle the band, removing the band from around the stomach. I then cut the tubing of the band, removing that from a 15 millimeter port. and then go to the subcutaneous reservoir as a second incision, remove the port and any of the residual tubing. For a patient that presented with pain, it's important to assess for signs of ischemia, but I would try, if at all possible, to avoid resection. And so only for a patient that has full thickness necrosis would I consider a resection. And hopefully you can do this in a limited fashion. This is going to be an ill patient, and avoid a formal reconstruction at that time. For ischemic signs only, so mucosal ischemia or questionable signs of ischemia, I would remove the band and just kind of wait in the operating room and reassess vascular viability once you have that band out. For a band erosion, most of the time this is not an emergency. A patient may present with lack of restriction or increased appetite once that band erodes into the stomach and is no longer providing restriction. But on occasion, this can present with an infection. And so if you have a patient that hasn't had a fill, that has new redness over their port, that should be an indication of a potential band erosion, or certainly if they're presenting with abdominal pain. And rarely these patients can be systemically ill from that band infection. This is usually diagnosed with an upper GI and complement with an endoscopy. Sometimes in an emergent setting, a CT scan can be very helpful also and confirm your diagnosis. A couple of months ago, I had a 45-year-old female that presented to the emergency room. She had had some left upper quadrant pain. She thought perhaps it was a muscle pull that had been significantly worsened over the past few days in conjunction with malaise, nausea, vomiting, inability to tolerate any PO, and she started to have high fevers. Of note in her history, she had a band placed several years ago, and at that time there had been an intraoperative gastric perforation. The surgeon had repaired the perforation at the time of the operation, but this put her at risk for having a band erosion in the future. She was noted in the emergency room to be febrile, tachycardic, and systemically ill appearing, and she was exceptionally tender over her port and had left upper quadrant guarding. We got a CAT scan to determine our diagnosis. And you can see on the left-hand side an intraluminal band with a significant amount of surrounding edema and inflammatory changes. And then on the right side, even the tubing, as it exits the stomach, you can see this inflammatory rind around it. So we took her emergently to the operating room, and the first thing that I did was an endoscopy. So you do an endoscopy, you can do that to confirm the diagnosis, but what I'm trying to do here is see that buccal, and you can see that the buccal is located on retroflexion, all intraluminally, and that allows me to alter the approach that I'm going to use to try to get this band out. The greater omentum was stuck to the tubing as we suspected by the CT scan. The mesentery and appendages off the transverse colon were stuck to the band, so we kind of had to tediously take this down. So we finally found the stomach and the entry site of where that tubing is now going into the stomach. So we're not going to see the capsule of the band here, because that capsule is intraluminal. So when you have a buccal that's completely intraluminal and 50% of the band within the lumen, you could do this approach where you do an anterior gastrotomy. And the benefit of this approach is you're tackling getting the band out away from the area of inflammation. So making a 2 to 3 centimeter gastrotomy, and then you're able to grasp the band from the inside. And then I cut the buccal as I had described earlier, and with that you can remove the entirety of the band once you've cut some of the tubing. I then closed the anterior gastrotomy separate from the entry site of where the tubing had entered the stomach with the erosion. So we have a nice clean staple line here where we removed the band. And then identifying where the band went into, where the tubing went intraluminal. And so there's just a small couple millimeter hole there for the tubing that then I can close in a more limited fashion than if I had to do a direct cut down in this area to try to remove the intraluminal band. And again, you can only do this technique if the buccal is intraluminal. And so trying to directly close that small erosion site from the tubing with stitches. And then making sure that our staple line is hemostatic. And then once I feel comfortable with the closure as well as the gastrotomy closure, we mobilized a small piece of omentum and brought this on top as an omentoplasty, just to reinforce that repair. And then we've finished the procedure with an endoscopy to make sure that we have a good closure of the erosion site. I did leave a drain in this patient that went underneath the liver over the repair, and then the case was completed by removing the residual tubing as well as the subcutaneous reservoir. The subcutaneous port is a site that you can see surgical site infections after the surgery, because often the reservoir itself is infected too. So you can make a decision on whether or not you want to pack that wound or try to close it. This patient, we did an upper GI postoperative day number 1. So on the left, you can see the scalp film with the drain. And then on the right-hand side, the images which showed an intact repair. She was continued on antibiotics and able to be discharged home from the hospital on postoperative day number 3. And then she had a follow-up endoscopy done at 2 months after surgery to confirm there were no further intraluminal lesions. In conclusion, lap band perioperative complications are very rare, and partly due to the minimal utilization of the band at this point. But in terms of long-term emergent complications, we see prolapse and slips, and be very mindful of the risk of ischemia, necrosis, and delay of diagnosis. And although often this is not an emergent operation, when a patient is presenting with significant pain, you need to take these seriously. And then the second being a band erosion, again, a rare complication for this to present emergently, but when it happens, you need to know where the erosion has happened, how much of that band is involved in the erosion, because that will alter your operative technique. Thank you for allowing me to present today on band complications, and I hope that next year we can all touch base in person at SAGES 2021.